Hello everyone. Last time I discussed about peripheral stigmata of liver disease. Today I will talk about evaluation of patients with possible liver dysfunction. Adequate evaluation of a child with suspected liver disease begins with an appropriate and accurate history, carefully performed physical examination, and skillful interpretation of signs and symptoms. Further evaluation is aided by judicious selection of diagnostic tests, followed by the use of imaging modalities and/or liver biopsy. Most of the so-called liver function tests do not measure any specific hepatic function because a rise in serum aminotransferase levels reflects liver cell injury. An increase in immunoglobulin levels reflects an immunologic response to an injury, or an elevation in bilirubin levels can reflect any of the several disturbances of bilirubin metabolism. Any single biochemical assay provides limited information, which must be placed in the context of the entire clinical picture. For a patient with suspected liver disease, evaluation addresses the following issues in sequence. Is liver disease present? If so, what is its nature? What is its severity? Is specific treatment available? How we can monitor the response to treatment, and what is the prognosis? Evaluation of a patient with liver dysfunction or suspected liver dysfunction starts with biochemical tests. Laboratory tests commonly used to screen for or to confirm suspicion of liver disease include measurements of serum aminotransferase, total and fractionated bilirubin, alkaline phosphates, gamma glutamyl transpeptidase, and PT and INR, and also serum albumin level. These tests are complementary. They provide an estimation of synthetic and excretory functions, and they might suggest the nature of the disturbance, whether it is inflammation or cholestasis. The severity of the liver disease might be reflected in clinical signs or biochemical alterations. When we see the clinical signs that shows or that reflects severity of liver disease, encephalopathy, variceal hemorrhage, worsening jaundice, apparent shrinkage of the liver mass owing to massive necrosis, and onset of ascites are a sign of severity. Whereas biochemical alterations which are reflective of severity include presence of hypoglycemia, acidosis, hyperammonemia, electrolyte imbalance, marked hypoalbuminemia, prolonged PT or INR that is unresponsive to parenteral administration of vitamin K. Acute liver injury or parenchymal disease caused by viral hepatitis, drug or toxin-induced liver disease, or shock, hypoxemia, or metabolic disease is best suggested by a marked increase in serum aminotransferase levels. Cholestasis, which is obstructive disease, involves regurgitation of bile components into serum, so the serum levels of total and conjugated bilirubin and serum bile acids are elevated. Elevation in serum alkaline phosphates, 5-nucleotides, and GGT levels are also sensitive indicators of obstruction or inflammation of the biliary tract. Fractionation of the total serum bilirubin level into conjugated and unconjugated bilirubin fractions helps to distinguish between elevations caused by processes such as hemolysis and those caused by hepatic dysfunction. A predominant elevation in the conjugated bilirubin level provides a relatively sensitive index of hepatocellular disease or hepatic excretory functions or dysfunctions. Alanine aminotransferase or SGP is a liver-specific enzyme, whereas aspartate aminotransferase or SGO is derived from other organs in addition to the liver. The most marked rises of ACT and ALT levels can be noted in patients with acute hepatocellular injury, for example from acute viral hepatitis, from toxic injury such as acetaminophen poisoning, hypoxia, or hypoperfusion. After blunt abdominal trauma, parallel elevation in aminotransferase levels can provide an early clue to hepatic injury. A differential rise or fall in ACT and ALT levels sometimes provides useful information. In acute hepatitis, for example, the rise in ALT might be greater than the rise in ACT. In alcohol-induced liver injury, fulminant ecovirus infection, various metabolic diseases, more predominant rise in ACT level are reported. In chronic liver disease or in intrahepatic or extrahepatic biliary obstruction, ACT and ALT elevations might be less marked. Hepatic synthetic function is reflected in serum albumin and protein levels, and also in the level of PT or INR. Patients with autoimmune hepatitis often have high gamma globulin levels and increased titers of anti-smooth muscle, anti-nuclear, and anti-liver-kidney microsome antibodies. A resurgence in alpha-fetoprotein levels can suggest hepatoma, hepatoblastoma, or hereditary tyrosinemia. Hypoalbuminemia caused by depressed synthesis can complicate severe liver disease and serves as a prognostic factor. Deficiency of factor 5 and of the vitamin K dependent factors such as factor 2, 7, 9, and 10 can occur in patients with severe liver disease or fulminant hepatic failure. If the PT or IRNR is prolonged as a result of intestinal absorption of vitamin K or decreased nutritional intake of vitamin K, parenteral administration of vitamin K should correct the coagulopathy, leading to normalization within 12 to 24 hours. Unresponsiveness to parenteral vitamin K suggests severe hepatic disease. Persistently low levels of factor 7 are evidence of poor prognosis in patients with fulminant liver disease. Interpretation of results of biochemical tests of hepatic structure and function must be made in the context of age-related changes. Normal growing children have significant elevation of serum alkaline phosphate activity originating from influx into serum of the isoenzyme that originates in bone, particularly rapidly growing adolescents. An isolated increase in ALP does not indicate hepatic or biliary disease if other liver tests are normal. Other enzymes such as 5-nucleotides and GGT are increased in cholestatic conditions and they might be more specific for hepatobiliary disease. Next to biochemical evaluation, the other is liver biopsy. Specimens of liver tissue can be used to determine a precise histologic diagnosis in patients with neonatal cholestasis, chronic hepatitis, non-alcoholic fatty liver disease, metabolic liver disease, intrahepatic cholestasis, congenital hepatic fibrosis, or undefined portal hypertension. The samples might be subject to enzyme analysis to detect inborn errors of metabolism and to analysis of stored material such as iron, copper, or specific metabolites. Liver biopsy can monitor response to therapy or detect complication of treatment with potential hepatotoxic agents. The other is hepatic imaging procedures. Various techniques help define the size, shape, and architecture of the liver and the anatomy of the intrahepatic and extrahepatic biliary trees. Choice of imaging procedures should be part of a carefully formulated diagnostic approach with avoidance of redundant demonstrations by several techniques. The first one is plain X-ray study. Plain X-ray study can suggest hepatomegaly, but sometimes hepatomegaly can be well described by physical examination. And the liver might appear less dense than normal in patients with fat infiltration or more dense with deposition of heavy metals such as iron on plain X-ray study. A hepatic or biliary tract mass can displace an air-filled loop of bowel. And the calcification may be evident in the liver, for example, in the parasitic or neoplastic disease, or calcification can be seen in vasculature, such as in portal vein thrombosis, or in the gallbladder or biliary tree, for example, in the case of gallstones. Collection of gas may be seen within the liver if there is an abscess, or biliary tract or portal circulations, for example, if there is necrotizing enterocolitis in neonates. The other imaging studies is ultrasonography or ultrasound. Ultrasound provides information about the size, composition, and the blood flow to the liver. Mass lesion as small as 1 to 2 cm might be shown, and this can detect stones in the gallbladder or biliary tree. Ultrasound can also assess gallbladder size, detect dilatation of the biliary tract, and define a coloidal cyst. In infants with biliary atresia, ultrasound findings might include small or absent gallbladder, non-visualization of the common duct, and the presence of the triangular cord sign and a triangular or tubular shaped pericogenic density in the bifurcation of the portal vein. Hypericogenic hepatic parenchyma on ultrasound can be seen with metabolic disease such as glycogen storage disease or fatty liver, such as due to obesity, malnutrition, or parenteral elimination or corticosteroids. The other is CT scan. CT scan might be more accurate than ultrasound in detecting focal lesions such as tumors, cysts, and abscesses. When enhanced by a contrast medium, CT scanning can reveal a neoplastic mass density only slightly different from that of a normal liver. When hepatic tumor is suspected, CT scanning is currently considered the best method to define anatomic extent, solid or cystic nature, and vascularity. Either CT scanning or ultrasound might be used to guide percutaneously placed fine needles for biopsies, aspirations of specific lesions, or cholangiography. The other is MRI. MRI is useful alternative that limits radiation exposure from CT scan. Magnetic resonant cholangiography can be of value in differentiating biliary tract lesions. For example, it can assist in the detection and the characterization of known or suspected focal level lesions, in differentiating obstructive from non-obstructive cholestasis, and in identifying the precise level of obstruction more often than that of the ultrasound. The other is radionuclide scan. Radionuclide scanning relies on selective uptake of radiopharmaceutical agents. This modality can help to evaluate patients with possible cirrhosis and with patchy hepatic uptake and the shift of colloid uptake from liver to bone marrow. The other is cholangiography. Direct visualization of the intrahepatic or extrahepatic biliary tree after injection of opaque material might be required in some patients to evaluate the cause, location, or extent of biliary obstruction. So this is all about evaluation of a patient suspected to have liver disease. Thank you for your attention.